Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. Thank you so much for attending this activity, this live activity, Improving Public Housing Health Center Service Delivery through Cultural Competence and Health Literacy. It is such a great honor for me to moderate this session and have a great presenter and a great panelist who will be introducing us to this topic, which is very important for the public housing primary care grantees and for all health centers located in or immediately accessible to public housing. Before we get started, we at the National Health Center for Health and Public Housing are very interested in getting information from you. If you have any history, any story to share on COVID-19, or if you have any best practices or any challenge, please make sure to contact us. We are very interested and we'll be very happy to hear from you and all the great work that you're doing. Thank you so much for the great effort, for everything that you're doing to serve the most vulnerable in the United States. So this is a live session, and the National Center is funded by HRSA to provide training and technical assistance to community health centers across the nation, and specifically those serving public housing residents. This is a live activity. At this moment, all lines are muted. We are going to have a Q&A at the end of the session, so save your questions if you have any questions, and you can ask your question either by typing your question in the question box or by using the raise hand icon. If you use the raise hand icon, your line will be unmuted and you will be able to ask your question live. As a brief introduction, there are 107 public housing primary care grantees and 385 health centers serving public housing residents across the United States. This is the most recent data from UDS 2018 data. And as we can see, in 2018, health centers in or immediately accessible to public housing serve 4.4 million patients. And those health centers have been reporting all kind of chronic conditions affecting public housing primary care, public housing residents. In regards to public housing demographics, and this is an introduction to the topic, there are around 2.2 million residents living in public housing. 38% are residents who are under the age of 17. Around 59% of them are female. 55% have less than high school diploma, and over 83% are below the federal poverty line. In a recent publication, this is a HUD CDC publication, Health Picture of HUD-Assisted Adults. This data was taken from NHCC and from the National Health Interview Survey, and then they found that those living in public housing and those having or receiving HUD-assisted help or who are in HUD-assisted programs are more likely to have chronic medical conditions when you compare them to the general population. This is from a similar publication. This is the health picture of HUD-assisted children. And as you can see here, children living in public housing are more likely to have or to experience social determinants of health, use the emergency room, and have other chronic conditions when you compare it to the general population. In regards to the impacts of housing and health, as you know, housing is one of the social determinants of health, and is linked to health outcomes. So by addressing housing as one of the determinants of health, we can improve the health of those living in public housing. Remember that this population are more likely to have diabetes, cardiovascular diseases, experience HIV/AIDS, or having some social determinants of health affecting their health. Not only housing, but low education and low health literacy. So those are the reasons why we believe here at the National Center for Health in Public Housing that it's very important to discuss this topic with the health centers. In addition to that, according to 2018 UDS data, the percentage of Latino population in public housing is higher than those in health centers in general. And when you compare the data from UDS in regards to a barrier to care, the percentage of those patients in public housing primary care reported that they prefer to receive services in other language than English. So it is my pleasure to introduce today's speaker, Dr. Abdin Novoa Rios. He is a native of Puerto Rico and is a social scientist and educator that has worked in the field of education, public health, and organizational development for over 3 decades. As both a practitioner and researcher, his formative background includes 6 earned degrees from Harvard University, UC Berkeley, University of Illinois, among other universities, as well as postdoctoral studies at University of Michigan and Oxford University. He was the editor-in-chief and co-founder of 2 Hispanic journals on social research, as well as author of more than 50 article manuscripts, and more recently a book, The Story of Latinos and Education in American History, 2019. As a social scientist, his work experience has been vast, having worked at the state level in public health, and which the federal government in education, then subsequently directing research initiatives in various domains in the nonprofit and corporate sector in both the US and abroad, with extensive focus on Latino issues, together with expertise and cultural competence in the delivery of education programs and public health services. Without further ado, I will turn it over to Dr. Novoa Rios.
Thank you, Dr. Leon. Let me. All right. And I'm trying to see the full screen.
You have to minimize it. You have to minimize the one that you have.
Try.
We're experiencing, we're having some technical difficulties, but we address the issue. Let me go going over some items. All
Right.
right.
These are true, false on demography. Current demographic shifts across the country are uniquely different from previous shifts in US history. That's question number 1. True or false? The second is demographic shifts always imply cultural change. Again, true or false? And the third and final question is current demographic shifts convey changes in the healthcare system. Once again, true or false? Now, this begins to give us a sense of your knowledge about demography. And for those of you wondering, the answer to all 3 questions is true. But let's not digress. Let's continue to gain a better grasp of these issues. The cultural shifts in America basically are of 4 sorts. Demographic trends will change the face of America considerably. As a result, changes in demography will always convey cultural shifts. These cultural shifts will inevitably lead to a different healthcare system, and such changes in healthcare will demand greater cultural competence. So America's demographic shift by nature implies cultural changes. It also implies major adjustments and changes in healthcare. And we should note that these current trends will continue long-term. As the face of America is altered, conditions will inevitably change. Now, these cultural shifts convey changes in national culture, heightened multiculturalism, diverse attitudes and behaviors, also reflected in music and food and dress, altering worldviews, greater diversity, more linguistic tolerance, even changes in languages or new lingo in languages, and in the American language mixed with other languages, especially the Spanish language, and so forth. So these are major. And so the challenge is major growth among racial minorities will create challenging conditions nationwide. In this sense, Latinos and Asian Pacific Islanders are the 2 groups that are growing considerably faster than all other groups in America. And this will affect the healthcare delivery significantly. Significance of this, the future of America is fully linked to the progress and prosperity of these rapidly growing populations. So for America to succeed, brown people, minorities, people of color must also succeed. So what do these trends indicate? Just very, very quickly, briefly. The white population is decreasing at about 5% annually at least the past 10 years, and considerably into the future. Also, the Black population has plateaued at around 13% annually. And this has been the case now for roughly 150 years, actually ever since the Civil War, where it was 14% and then down to about 13%. Now it's back up to about 13.4%. But all that to say that it has plateaued. It's not changing significantly. Differently from that, the Asian American or the Asian Pacific Islander population is growing significantly, but 3/4 of that growth is due to immigration. Therefore, these racial minorities are increasing much faster than whites. The result, minorities and specifically Latinos will become the future of this country. Now, given that trend, Among Latinos, growth is phenomenal. End of last century, for example, Latinos had become the largest racial minority nationwide already. In 2011, more minority babies were born than white babies ever, for the first time in US history, with Latinos as the vast majority among them. Several years later, academic year 2014-15, marked the first time public schools K-12 became non-white majority. Last year, among the 15 largest school districts, for example, Latinos represented the highest percent in 13 of these districts. That's phenomenal growth. So by the end of this generation, within the next 20 years or so, the US will be a majority minority or a minority majority, either way, nation by around 2043, with Latinos nearly 1 in 3 residents. So the growth, as we can see from this slide, is hyperbolic. And this has been going on since around 1970 in a very exponential manner. And if you see the last bar, which reads 2016, if we superimpose 2020 based on the upcoming census at this point, we will see that it continues that hyperbolic trend. And so what does this mean? Very quickly, different from the Asian Pacific Islander population, there's an important distinction that the Hispanic growth is no longer due to immigration. And if we see the comparison of births versus immigration, that is US births versus immigration, that seemed to be the case up until around the year 2000. It has now reversed, where US births are much greater and will continue to be much greater than immigration. So even if you halt immigration, the net reproduction rate, or the NRR rate, of the Latino population will continue unabated. And so that's a major shift that is occurring. If we take a look at the US population, and this map begins to give you the pixel almost of each of the counties. There are several thousand counties in the US by state. Geographically, you begin to see from the 2010 census 10 years ago that a vast majority of the country, almost 3/4 of the country, have a very high, a fairly high Latino or Hispanic, and I'm using the terms interchangeably, population. The dark red here represents 12.3 or above in terms of representation in that county population. But this map does not show the true reality of the growth pattern because it's static at 2010. So the next three very quickly will give you a sense of the growth projected between this map 2010 to 2030. We are now midway 2020 in that projection of 20 years. So looking at first the white population, Caucasian population, then looking at the African American population and subsequently the Latino population, we begin to see how that is impacting the country in terms of representation. Here now, rather than pixels, we have larger sectors by state represented. And on this map, as the next two, the projected white population change from 2010 to 2030 is showing with a decline on the yellow-red spectrum versus a growth from the light blue to dark blue spectrum. And as we can see, which is surprising, maybe to a lot of you, is that if you take the center of the country, it's losing population relatively to other groups. And if you take the Northeast, the same appears to be the case. If you look at California, the same appears to be the case between now and the year 2030. Now, let's keep this image in mind as we look at the next map, which is a projected African American and Black population change. And here we begin to see states like Minnesota, Wisconsin, and then we begin to see states like Maine and Vermont and New Hampshire with a tremendous population growth that was unanticipated some years back, partly because of the lower growth of the white population, and so it's a relative indicator in terms of where it will be within the next 10 years. And this may be a rather surprising map, but it shows us how that projection will go. One more map is the Latino map, and here you see an incredible projection the next 10 years. And this is now a good chunk of the country with very, very few exceptions. And again, it's the dark blue that shows maximal change. And this change in dark blue, as per the legend we saw earlier, is 40% representation, which is incredibly high. Now, keeping these maps in context, what it also begins to show is if we begin to look or examine low income or income in general, this particular graph begins to give us the median per capita income by race. This is taken from several years ago, 2016. As census is always several years behind the actual year that it is viewed. We begin to see now that the Black and Hispanic population is almost half income as compared to the Asian Pacific Islander and the white non-Hispanic population. That has incredible repercussions demographically. If we take the maps we just saw and project income in terms of that growth, the country begins to look like it's getting less and less income over time and becoming more and more poor over time. And this will dramatically also affect the public housing percentages that we saw at the beginning. And then if we begin to look at the juxtaposition of the Hispanic population with the Asian population, where again, the ratio of income is almost a 2-to-1 ratio, but the growth, the percent representation of Latinos is about 3 times higher than the representation of Asian Pacific Islanders. The Latino population is now right around 19% of the US population. It begins to show some of the tensions that may be existing in terms of some of the fast growing, or the differences that may be existing between some of the fast growing populations in this country. Now, what this begins to also tell us, in a nutshell, is a summary statement of this sort. Shifts in the general makeup of the country will be causing significant changes in the overall national culture of the country, as this change will also create major challenges to the healthcare industry. And so if we were to ask what's going on, what's happening, 3 critical bullet points. 1, dramatic demographic shifts are occurring where Latinos are front and center. 2, major browning and or Latinization and or cultural shifts of America are taking place. And 3, nearly half the country, largely minority, has been ignored and grossly underserved, especially for healthcare, housing, and education, by whatever category we look at in terms of demographic projections and counts. So implications of this are vast, but one of them is that no country can sustain a prosperous future if half its population is in poor health, poorly paid, low income, and grossly undereducated. So let's take a quick pause right now in terms of questions regarding cultural competence as we get now into that new area. And the 2 questions are, number 1, have you participated in a cultural competence training? Yes or no? And secondly, if yes, how helpful was it on a scale of very helpful to not helpful? And let me pause for about 20 seconds and see if I can get a read in terms of your response.
You have 20 seconds.
So let me do question number 1 first.
Okay. Yeah.
100% of participants have participated in a cultural competence training. We will proceed to question number 2.
So the responses are that everyone listening has participated in a culturally competent training.
Yes. And I will proceed to question number 2. %, voted somewhat helpful and 50% voted very helpful.
So it was split between very helpful, 50%, and somewhat helpful, 50%. Very good. Thank you. That begins to give us a sense of your background and training in the area of cultural competence. In terms of how we define cultural competence, in a nutshell, it's the capacity to work effectively with persons from different cultural backgrounds and beliefs, but not just racial minorities. And I have been concentrating the data demographically in terms of racial minorities because that's the vast number when we talk about cultural competence, but not the only definer of cultural competence. And that needs to be firmly underscored. Now, as healthcare is a cultural construct based on beliefs about the nature of illness and the human body, cultural competence impacts care because it helps interpret alternative views regarding health and healing. It also helps us understand how health is being perceived by others. It is also very respectful about what type of health care is acceptable. And it helps to differentiate among multiple types of treatment, many that can also be culturally based. And 5, in terms of the bullet points in front of you, it offers alternative ways providers can address and better communicate basic information to different groups. And it may also imply different standards for higher quality healthcare to diverse populations. So it's not one size fits all. But the bottom line of all of this, from the cultural competence perspective, is that it increases overall patient comfort and overall access to health care. Now, let me give you a couple of axioms regarding cultural competence that I think are important to underscore. The first is that it's not about affirmative action, but about the browning and the cultural shifts of the nation, where it's becoming very strongly non-white in composition. And so it is not just about counting heads, but about making those heads count. And that's a major distinction. The third area is that it is less about individual differences and more about institutional climate and overall institutional cultural acceptance and cultural competence. And let me hit number 4 and then summarize 3 and 4. it is also not just about cultural competence, but about managing and balancing differences in society and in the healthcare setting, the healthcare system in general. What am I saying? Basically, when we look at cultural competence, we're looking at individual, personal cultural competence. Now, we know that that's a long continuum between near zero to very, very high. No one is fully culturally competent. There is no such thing. But on that continuum, we continue to look at individual cultural competence. However, we sometimes neglect institutional cultural competence. And that is the belief that if an institution has a lot of workers, if its workforce is highly culturally competent, therefore the institution is highly culturally competent. Not so. That's a major, major distinction. Many institutions are not culturally competent in terms of their policies, their practices, and everyday action. And so it may have culturally competent workers, but it does not provide access for these culturally competent workers to do the work that they're capable of doing because of policies and practices that sometimes get in the way. So what we want to emphasize in cultural competence, even beyond the individual, is the institution. And in fact, the research now for decades is showing us that the more culturally competent the institution or the setting is, whether it's a clinic or a hospital or an agency, the more eventually its staff, its workers, will become also more highly culturally competent, so that it works more from the institutional setting than from the individual setting. However, all that said and done, in terms of 3 and 4, both have to be working in sync. And it is important to make sure that both are working, so that it's not a matter of an institution just sending its staff to a culturally competent training for maybe 3 or 4 days out of a given year, and then come back to an institution that does not allow them to exercise the new information. It's important for them to realize that it has to be carried out within the institutional setting itself. And number 5 is, in fact, almost a new paradigm that is occurring. And that is what we call the platinum rule of diversity, which is treating others as they would like to be treated, versus the golden rule, which we all know, treat others as you would like to be treated. That paradigm shift is enormous to understand. And so in a nutshell, these are some of the new axioms in terms of cultural competence and what it means in context. Now, moving on to health disparities among diverse groups. Health disparities refers to differences in health that are closely linked with social and economic disadvantages. And so let's begin to talk about facts about Hispanic health, then in general, and African Americans. Demographically, Latinos are greater than 80% of immigrants. About 10 million are non-citizens, and 90% of all English speakers are Hispanics. Also, 1 in 5 live below the poverty line, with 1 in 4 unemployed. Yet, astonishingly, the US is now, as of the past 20 years, the second largest Spanish-speaking or Latino nation in the world by numbers, close to 60 million. So if we were to look at the numbers in general, think of the fact that 1 out of every 5 US residents is Hispanic. 1 out of every 4 is now in the K-12 public school system at large. And 1 out of every 3.5 is under 5 years of age. If we flip that population pyramid right now, we would be getting very close within another generation or so into what the future of the country will be looking like. Number two, Latinos, given all of these numbers, are the least likely to see a medical doctor among all groups in America. In terms of obesity, 23% more obese than counterpart whites. More than 1 in 4 adults lacks a usual provider, and almost half never visit a medical institution, a medical doctor during a typical year. Now, with public housing, these statistics are greatly more exacerbated. These are general statistics at large. 1 in 4 Hispanics also do not have insurance, compared to 12% for Blacks, and 3 times more likely to be uninsured than whites. Hence, they are 50% more likely to die from diabetes or liver disease than whites, yet with nearly similar prevalence rates. And that's a very important distinction. Health risks vary depending on whether Latinos are born in the US or abroad, and this is an astonishing statistic. With better health outcomes for those born in the Caribbean and Latin America, which means that the healthier Latino is the incoming Latino to the US population. And in fact, data-wise, the longer Latinos are in the United States as recent immigrants, the sicker or the least healthy they become. And that's an ironic situation, and one that we need to look at a little bit more carefully as to what that means and why that is occurring. But that is now a statistical fact. Now, on the positive side, as Hispanics are more than a decade younger than whites, the steps they now take to avert disease will go a long way. Hence, early detection and follow-up become highly critical. Now, despite all these statistics, we end with number 8 bullet, which shockingly tells us that despite poor health, the Hispanic lifespan is 81.8 years versus 78.8 years for whites. Now, we can go into a long series in terms of why that might be the case. We say it's because of our diet, our way of life, etc. There are a number of articles that have recently come out in terms of this, and it's sometimes what we call the Hispanic or the Latino paradox. But something else is going on above and beyond that may be related more to resiliency and other factors. But that's a very interesting statistic that is always important to point out. Now, when we move to facts about African American health, we begin with the fact that after 250 years of social segregation and discrimination, current health data confirm African Americans are the least healthy racial group in America by all measures. Now, important to know, number 2 here, is that while leading causes of death have decreased, they are more likely to die at earlier ages from all causes. So life expectancy is 4 years lower than for whites on average. And it is now clear that African Americans receive fewer medications due to low income and insurance status, but also to misinformation, while oftentimes lacking basic information altogether. Number 4, while prevalence rates are similar to whites, young African Americans are living with diseases more common at older ages for others. Example, at ages 18 to 49, African Americans are twice as likely to die from heart disease than whites, and 50% more likely to have high blood pressure, diabetes, and stroke at ages 35 to 64. Violence is also a major determinant of health disparities, and is a major cause of injury, disability, and premature death. Black males are 6 times more likely to die of homicide than whites, with firearms as the leading cause. In terms of imprisonment, about half of all inmates in US jails and prisons are Black, with Latinos as the second largest group. Both groups suffer from infectious and chronic diseases. For Blacks, the rates are 4 to 10 times the total population, and with HIV rates that are 13 times higher than the US average population. And finally, national surveys show lower rates of mental illness for both Black and Latinos as compared to whites, yet they suffer more from psychological distress, and even the proportion of youth contemplating suicide has been 40% lower among Blacks compared to whites, and also quite low for Hispanics, which again seems to be a contradiction to the previous data, but at the same time points out to high resiliency in the population. Now, in general, facts about minority health: more than 1 in 5 speak a language other than English, and 1 in 7 are foreign-born and more likely to lack health insurance. Latinos and Blacks are much more likely also to distrust the medical profession than whites. And all too many minority patients are afraid of doctors, while physicians are uncomfortable conversing with patients that are culturally different. Typical physicians interrupt patients within the first 20 seconds of conversation, unbelievable as it may sound, regardless of language. And this happens even more likely with racial minorities. Now, the good news of all of this is that patient satisfaction greatly increases by enhancing cultural understanding, while the risk of malpractice is also greatly reduced, saving time and money. Now, in terms of prevalence rates, if we look at this chart, looking at the top 10 prevalence rates by racial group based on most recent 2017 data. And if we focus on the first 5, because this is a complicated table to digest quickly, but if you focus on the first 5 rankings, we begin to see that they're not all that dissimilar for whites, Hispanic, Blacks, Asian Pacific Islanders, and Native American Alaskan Native. Heart disease, for example, the red, the burgundy, is top on the list for all but the Asian Pacific Islander, and cancer ranks second and flip-flops for the Asian Pacific Islander with heart disease. In terms of accidents, the yellow spectrum, also very similar across groups, and even diabetes, fairly similar across groups. Now, this begins to get a little bit more convoluted, more complex on the rankings from 6 to 10. And it will take a little while to digest all of this. We don't have time for that. But we begin to see some areas of differences. Let me point out one particular one, and that is the white rectangles here. For the African American, number 7, homicide, and number 10 for Blacks, septicemia. For Asian Pacific Islanders, essential hypertension ranks number 10. None of these ranks in any category for the others, and so forth. But it's what this does not show us, however, is the fact that it's not just the prevalence rate that is important, but also access to medical care. And so death rates are much higher for the minority sector than it is for whites, because they do not get the medical attention necessary. So when we begin to look at disparity, it's not just the prevalence rates, but it's also living with that disease early on and not getting the attention that is needed. Health literacy is about the skills needed to act on information that will lead to a more healthy life. And culture affects how people understand and respond to information about health. Now, I have a quick question in terms of literacy on linguistic diversity. What has been your experience working with individuals with limited English proficiency? And again, it's a quick poll in terms of very often, sometimes or periodically, hardly at all, and never. And this time we'll take 10 seconds as we're mindful of our time in terms of your response.
And 100% of participants voted sometimes or periodically.
100% responded sometimes or periodically. Interesting. By the way, all participants, you are a little bit different from the average, so that you have been involved with diverse communities considerably more than the average health worker, which is good to know. And you probably have a higher repertoire of this issue and what it encompasses than your average health worker across the country. So finally, and you probably know some of this, sample issues and concerns around health literacy are rather important to know. As we see here in terms of these 10 bullets, and I'll go very quickly, 1 in 2 adults patients has difficulty understanding basic health information, regardless of language. And this is especially true among the elderly, and especially true for those in public housing, much more so. This includes directions regarding medicines and dosage, including simple instructions like taking a pill 3 times daily. And the question is, what exactly does that mean? And how do I parse that out in terms of time, et cetera, et cetera. Many patients don't know how to read a prescription label or even a nutritional label. Secondly is the mismatch between a clinician's level of communication and the patient's level of comprehension. That is rather significant and distant. Third is overestimation of patients' health literacy level based solely on subjective assessment or bias of projections that are not evidence-based. 4, incompatibility among patient-provider system, knowledge of health literacy policy procedures, practices, and guidelines. And that incompatibility is considerable. 5, adherence needs critical cultural orientation. 6, comfort and privacy is difficult to maintain and at times embarrassing, especially when another practicing doctor or attendant is brought into the relationship without patient consent. This happens a lot more frequently than we would like to give credibility to. 8, it is confusing for many to know that more than one physician may be necessary for treatment. This is not highly understood among the populations that we're talking about, and certainly in the public housing sector. 9, patients may need to bring others into the conversation to help make decisions and ensure security. And 10, and by the way, the list goes on, but number 10, accommodations are important for interpreters of the same gender, and interpreters should be of the same gender. And sometimes these accommodations are not easy to make, or sometimes in many settings, unfortunately, there are not interpreters to be found, or interpreters are sparse. And so these are some sample issues and concerns around health literacy in general. So we've covered the areas of demography and its impact to the area of cultural competence and why it's needed and why it is important, into health literacy and how it all comes together from that vantage point. And so given our time, I wanted to close it for any questions and answers and turn it back to Dr. Lowe.
Thank you, Dr. Noboa Rios. So the pending overview of cultural competence and health literacy.
Well, it's great. Starting for our next 3 sessions, and remember that we are going to have our second session on Tuesday, April 15th at 1 p.m. Eastern Time. So as Dr. Rodriguez said, it's time to get some questions. If you have any questions, you can type your question in the question box, or you can use the raise hand icon and the line will be unmuted. And Dr. Rodriguez, well, we wait for some questions. You said something really interesting, and this caused some confusion regarding the 2 terms, Hispanic and Latino. Can we go a little bit further and just make the clarification between the 2 terms?
Thank you. The 2 terms are fully synonymous. In the 1980 census, it was decided to use the term Hispanic. That later was modified to use the term as an alternative also Latino or Hispanic/Latino. Over time, Latino has become more and more in vogue, and so we normally refer to a Latino population rather than an Hispanic population. Just like the Black versus African American, over time, or Negro to Black to African American has changed in usage, so has the term Hispanic Latino. Normally, if you look at the country at large, the name Latino is highly acceptable. Now, it was not some years back in particular sectors. There is one particular sector, however, where the term Latino is not highly respected or used, and those are portions, very small portions in the state of New Mexico and some even smaller portions in the state of Colorado. Hispanic normally conveys to them being an Hispano going back to the old world, Spain, and so some of these sectors see themselves as direct descendants from Spain and refuse to use the term Latino. For that reason, they trace their ancestry directly over 400 to 500 years back to Spain. And there's a history there, but without getting into a lot of social dynamics about that history and what it may imply, the term Latino now is becoming more and more in vogue. One last statement about Latino is that it is also a Spanish word. And so in Latin America, we use the term Latino quite often, and in the Caribbean. And so it is more in sync with the Spanish language.
Thank you. Thank you for the clarification. And Chantal, any questions in the queue? No questions?
No questions?
All right, let's see if we get additional questions. But I do have another question for you, and this is regarding the Latino population in general. We've been talking about whites, discussed African Americans and Asian Americans, and the Hispanic or the Latino population has people from different minority groups. You know, among the Hispanics, we have blacks or Asians or whites. Is there any difference when you see the chronic conditions that you see, or by geography? You know, for instance, those in the Caribbean or those in South America. Is there any? Have you seen or have you studied any of these differences?
Yeah, there are some differential patterns there by far. Puerto Ricans and Mexicans, for example, have much higher diabetes rates than some of the others. Puerto Ricans and Mexicans are about 80% of the entire Latino population. USA, followed by Dominicans, and then Central Americans and Cubans, and then the rest of South America, with smaller percentages. Altogether, there are about 20 Latino nations that compose the Hispanic population throughout, and that includes Spain. It also, but it does not include one country in Africa, Equatorial Guinea, by the way, which speaks only Spanish. So it is not considered a Spanish country per se, but linguistically, it's the one country that speaks only Spanish that is not a Latino country per se historically. But generally we say there are about 20 nations, 20 Latino nations. And I'm including Puerto Rico as a nation, although that's disputed, obviously. But otherwise it would be 19 plus 1. And then plus 1 again in terms of Equatorial Guinea. So it can get to be somewhat confusing, but generally we're talking about the 4 groups that I mentioned: Puerto Rican, which is now split between the US and the other Puerto Rico; Mexican, which is by far the largest Hispanic group; and growing numbers of Dominican from the Dominican Republic; and an older group that has been here for a while is the Cuban American group. And now the recent increase from Central America, primarily El Salvador, Honduras, and Guatemala, and then of course all of South America. We normally do not include Brazil when we talk about Hispanic America, and so that's an important distinction. Otherwise the numbers will be even higher. So in a nutshell, there are differential patterns in terms of incidence prevalence rates by nationality. And that may be a topic of later discussion in the future. But it's important to know that it's a much more variegated, a much more diverse group than a simple terminology or a simple label would convey. Not all Latinos are the same.
Right.
There is a lot of diversity within the Latino population, from very, very hot in the Caribbean and upper portions of South America to very, very cold, to Tierra del Fuego in Chile, which is colder than any spot in the United States and most spots in Canada. So we are a very varied culture despite the common term and the common language of Spanish.
Thank you. Thank you, Dr. Rios. Questions in the queue? No questions. All right. I just have one more question for you, and this is like a follow-up question. I have the privilege to work with several health centers across the nation, in California, Florida, Illinois, New York, New Jersey, Texas, where you have a high concentration of Latino population. Due to the diversity that you are mentioning and the chronic conditions affecting, you know, the Hispanic population, depending on the area or region where they are, where they live, or where they used to live. What do you see the need to keep all these cultural competence training, because this is ever changing, this is evolving. So according to the responses that we received, we have most of the, or if not all of the attendees who have been or who have received cultural competence training. So in the future, do you see the need of modifying these trainings or updating what the content of these trainings?
By far. The modification should be made at two levels. One is regionally, and the other one then becomes specifically to particular diverse populations, or the diversity within those populations, whether they be Hispanic or whether even they would be African American, as there is also a big distinction between the native African American versus the African from Africa. Nigerian, for example, being the largest group that is not indigenous historically. So that we need to be careful about cultural competence training and not go into the one-size-fits-all mentality, which is very, very important. The other part that I have found, and I've been a cultural competence trainer for years myself, back in the days of the dinosaurs, but it's interesting that we have always focused on individual cultural competence as opposed to institutional cultural competence. And having dealt a lot in the mental health field, for example, we became very aware that we needed to address institutional cultural competence among provider agencies, even more so than individual cultural competence, because the rate of institutions missing the boat and assuming that they can just send their staff to a training would be sufficient became rampant in the 90s. And I think that that's still a major misperception, and that needs to be addressed in cultural competence training. Very few trainings deal with that.
Thank you, Dr. Navarriez. One more time, any questions in the queue?
Yes, we have two.
Okay.
The first question, is there any evidence to explain why Latinos might have a longer lifespan than whites? I will offer one relevant fact, which is that only 10% of Latinos smoke, while 16 to 17% of whites smoke.
Well, let me take a stab at it, but also turn it to Dr. Leon, who has probably more expertise on this than I do. But I would say that one of the areas that we've been looking at has been the area of our diet. And it's interesting that when you look at the Caribbean diet of rice and beans, it begins to resemble more the Mediterranean diet than any other diet, despite many of the fried foods that we have. We do have a good number that also use fruits and vegetables in our populations. Now, beyond the diet, we also have a different social lifestyle. And we have been finding out a lot lately. Malcolm Gladwell has written about this in terms of the fact that lifestyle also has a lot to do in mentality, mental health. Our focus on life has a lot to do with longevity. And so the social life that Latinos display, whether in music or dance or just generally socially, gives us a better perspective of what life is all about. And it also lowers a certain heightened anxiety about life, lo que será, será. And from that perspective, we're finding out that, in fact, despite the obstacles, you make the most of what you have. And that life mentality, it goes a long way. And we believe that that has a lot to do with longevity. The other is the family cycle and the family support system. We are very, very familial in our orientation. For example, we do not strongly, even in sectors of Puerto Rico, have our adults or our seniors be put away or be somewhere different from the family itself, from the nuclear family. So the belief is that we bring in our seniors to live with us. And from that vantage point, there are many more abuelas y abuelos that are living back with the nuclear family, no longer in isolation in their old age. And that helps a lot in terms of longevity of life at the latter stage.
I agree with you. I believe those are the most important aspects of the reason why Latinos, live longer and we are healthier. Depending on, I still have my, as you mentioned, the Latino paradox. I still have some issues with the Latino paradox. Yeah, it's difficult to digest, and it will depend on if you are first, second generation in the United States, for instance. But I want to be respectful of the attendees' time. So the question that we have, please, if we can, if you can submit it to Dr. Novoa Rios, and we will make sure that they receive the response via email. All right. So thank you for being with us this afternoon. We hope that you enjoyed this conversation, and we look forward to seeing you in April when we have the second session. Good afternoon. Please please remember to respond to the survey. Your responses are highly appreciated. Thank you and have a great afternoon.